And first of all, I'm extremely thankful and privileged for giving me an opportunity. This is my first time I'm presenting something at Jalna, but I do come regularly for the cases. I thanks to President Dr. Roke sir, Secretary Dr. Wag sir, Mante sir, Shekhadar sir, Udan sir, and all my guru from Aurangabad, Dr. Gade sir. So without wasting much time, robotic knee replacement has been hot topic which is being talked recently. So we all know that total knee replacement is a gold standard in osteoarthritis, but still there are 20% of unhappy or unsatisfied patient after total knee replacement. And why is that so? Is the one of the reason is the implant position and the limb alignment. So surgeon is able to select the desired implant and alignment intraoperatively with the robotic arm, and it gives execute the plan with the high degree of accuracy. So we all know this osteoarthritis classification, Kilgren and Lawrence classification with grade 0 to grade 4. This is a pictorial example of the osteoarthritis KL grading scale. Mild, moderate and severe, where in severe osteoarthritis where the joint replacement or total knee replacement is this solution. So what we do the convention, what we do in conventional total knee replacement and how the robotic is different. So we in conventional look at the mechanical axis, anatomical axis, transepicondylar axis, posterior condylar axis. So while doing the distal femoral resection, we put the intramedullary rod which can be 5 to 7 degree valgus. We can put only 3 degree of external rotation and 3 degree of flexion. But in the robotic, we can definitely adjust intraoperatively as per the patient anatomy. So femoral AP sizing, where the conventional anterior-posterior referencing with the stylus, but robotic you can give the external rotation and distal cutting, and the stylus as you want, how much you want. So proximal tibial resection in conventional is with the extramedullary jig, manual slope is to be adjusted. Robotic you can plan it preoperatively, adjust intraoperatively, and you can confirm by validation. So sizing again AP, and before doing the you have to while performing the robotic you have to define the certain points. So defining the femoral axis by femoral head, you have to rotate the femoral head and you have to mark the 14 static points, and that point should you have to in a circumduction gait you have to move, stop and repeat and 2 mm apart, and then you have to take the femoral canal entry. We have the Navy tracker. Okay, so we have you by that you define the femoral axis, femoral mechanical axis. You have to define the posterior condylar axis, so that posterior condylar define the posterior condylar axis, and white side line by pointing this anterior and posterior trochlear groove, which should be at least 20 mm apart and minimum of 3 mm from the femoral canal entry. So this is the conventional one. And defining the transepicondylar axis, you have to mark the medial epicondyle and the lateral epicondyle. This femoral resection, we have to mark the medial femoral condyle, the distal surface, and the lateral femoral condyle. The 5 mm apart, not to posterior, software will determine most of the distal one. Anterior cortex to avoid the anterior notching and anterior-posterior referencing. So this is we do. For the tibia, we have to give some reference point, that are the medial malleolus, lateral malleolus, tibial canal entry where your ACL is sit, the posterior cruciate ligament, and by conventional we define with this mechanical axis, defining the tibial mechanical axis with conventional jig. So this is anterior posterior axis with PCL insertion point, posterior to the tibial spine in the center of the PCL attachment. And the medial third tubercle, the point that the study does have the recurvatum, which is of 16 degree. So in that case, you need to, while doing the conventional, you have to adjust manually very much. You have to give the excess rotation, but you cannot judge how much is the rotation is to be given, how much of the distal femoral condyle or the posterior lateral condyle you are cutting. So, but the robotic does give the ease while planning. This is the post-op X-ray. I adjusted. I've hardly done any soft tissue release in this case. This is the post-op where I got the 2.5 degree of valgus, and I could achieve from recurvatum I could achieve the flexion, and this much of the flexion will get corrected with with physiotherapy. And this is the scanogram. You can see the pre-operative scanogram, which was right for 20 degree, 22 degree valgus, and now got corrected to almost normal mechanical axis. So this is her gait at 2 weeks. This is her knee flexion at 2 weeks. This is her active SLR and quadriceps functioning at 2 weeks. This is another case. This is the simple varus, which is of almost 12 to 15 degree, which got corrected to almost neutral. This is AP. This is his gait at within 4 weeks. This is his stair climbing. Another patient, this has been recently done. This man able to sit cross-legged within 4 weeks. I got the correction almost of 15 degree. So robotic TCR it's advanced technology. It has a learning curve. It does have the costly affair, but it has a smaller incision. It does create the less blood loss and faster recovery. Even if you search on this, the couple of days back only I was searching how many literatures come up with the robotic. So whenever the experience meets with the technology, you get the best results. So the today's era is evidence-based practice, but more on that evidence, experience, and technology it gives you ease and the comfort for the treatment. I thank you. I requested them to present another lecture, 5 minutes of scopy lecture, which was earlier planned last month, but I'll finish quickly. So this was my multiligamentous knee injury talk. Initially it was the